Hello, this is Michelle Bishop, and my project, DNP project, was on decreasing fluid overload in hemodialysis patients. My chair was Dr. Moyer. The problem is hemodialysis patients do not get adequate education with follow-up to help manage fluid overload. Now, this necessarily isn't the clinic's fault or the nurse's fault. The problem is that the nurses are extremely busy. They have 12 patients per shift. There are techs to help. They typically have two techs to help them with those 12 patients, but of course, the techs can't do all the documentation. The nurses have to do it, and the nurses have to do all the patient teaching. There's alarms going off all the time. You're having to check all the patient settings, make sure they've been set up correctly. There's a lot going on, and it's really hard for a nurse to really concentrate on providing education to these patients throughout the process. They try to do it in short tidbits here and there, but it's hard to do it being uninterrupted. Hemodialysis patients who get fluid overloaded tend to suffer from shortness of breath due to the pulmonary edema, and then a long-term complication is congestive heart failure. The purpose of this project was aimed to educate hemodialysis patients on problems associated with fluid overload, to decrease their intradialytic weight gain, which I will refer to as IDWG, decrease their blood pressure, which will be BP, and then decrease hospitalizations. The PICO question was, do dialysis patients who participate in a more progressive education program with follow-up by an advanced practice nurse concerning healthy lifestyle, self-care, and fluid management have better self-management of fluid status, lower blood pressure, and less hospitalization? The background, the scholar is an acute care dialysis nurse at a local hospital. We see many hemodialysis patients regularly for problems associated with fluid overload. The project was performed at an outpatient hemodialysis clinic in the Mid-South area. The clinic has approximately 150 patients that are seen 3 times a week. The significance: having a APN provide regular education to patients with follow-up, especially follow-up after a hospitalization, would help improve patient compliance, help overwhelm nursing staff and dialysis centers, decrease healthcare and Medicare costs by decreasing hospitalization. The patient comfort would be improved, and there would be a delayed development of congestive heart failure. My literature review initially came up with like 5,000 articles, and I had to narrow it down. I finally got it narrowed down to 12 articles that were chosen and grouped in the following categories: compliance and behavior, fluid restriction maintenance, rehospitalization, quality of life, and education. The incidence of risk factors: 63% of end-stage renal disease patients are managed 3 times a week by hemodialysis treatments. Approximately 700,000 patients in the U.S. are on hemodialysis. Other patients are on peritoneal dialysis. Survival rate for end-stage renal disease patients at 1, 2, 3, and 5 years is 79.9% for the first year, 67.9% for the second year, 57.6% the third year, and then 41.4% by the 5th year. 35.4% of hospitalized end-stage renal disease patients require rehospitalization within 30 days. This is according to the United States Renal Data System from the data from 2019. Fluid restriction maintenance: the most complicated and frequent risk factor of a hemodialysis patient is fluid overload. The fluid overload results in hypertension, pulmonary edema, and congestive heart failure. When a patient comes to the ER, typically it's because they're not managing their fluid or they have missed dialysis treatments. And sometimes it builds up over time because they're cutting their treatment short. So They come in, they can be extremely hypertensive. Many of them require a cardine drip. Many require an ICU stays. Some even require non-invasive positive pressure ventilation or even intubation. And then their long-term complications are congestive heart failure because the heart is always getting overstretched with the excess fluid, and over time the heart weakens and they have heart failure. 59.5% of hemodialysis patients do not correctly manage their fluid intake, which results in the fluid overload. So again, cutting and shortening the dialysis treatments can lead to the hypervolemia, and then, of course, just not managing their fluid. There is a 30% increase in mortality when treatments are missed and shortened regularly. Patients not complying with fluid restrictions are a risk for fluid overload, emergency room visits, and hospital admissions. They also discuss how treatment adherence leads to frequent hospitalization in dialysis patients. And these are the articles from Parker 2019, Snyder et al. From 2020, and Clark Kudia et al. From 2020. All of these articles talked about the same issues. The educational methods I used in this project was the teach-back method. The teach-back method gives patients an increased sense of responsibility and self-awareness because their ability to perform self-care behaviors yields better outcomes and improved quality of life. And this is backed up by studies by Ebony et al. 2020 and Rahmani et al. 2020. Motivational interviewing was utilized in studies by Russell et al. And Okay and Kutlu from 2021, which resulted in improvement in patient compliance and outcomes, resulting in improved quality of life. The primary goals of renal failure patients are fluid restrictions, number one. Dietary restrictions are very important also because sodium, when they're having too much sodium, it makes them more thirsty. They drink more fluid and they retain more fluid. So it's just a double sword, making their fluid retention worse. Taking prescribed medications. Some of them don't take their blood pressure medicines like they should, and then they get extremely hypertensive. And then just following their scheduled dialysis treatments. So many times when I have patients come in the hospital, they say they didn't go to dialysis because they didn't feel good. So, and it's not that they were having diarrhea or vomiting or anything, they just didn't feel good. And it's hard to make them understand that the buildup of toxins in their blood is what's making them not feel good many times. And so they need their dialysis treatment, plus the excess fluid makes them feel bad. So it's hard to make them understand that they need that dialysis. And then sometimes they just come off their treatment early because they're not feeling good. If their blood pressure drops, it makes them not feel good, and they want to come off. Hypervolemia is a major complication of renal failure patients, which leads to hospitalization due to the difficulty breathing. And it also leads to edema, hypertension, increased strain on the heart, and hospitalization. And this was discussed in multiple articles. The inclusion criteria of my project, the patients had to be 18 to 80 years old. The EMR documents that the participant had been in the dialysis clinic for more than 90 days with a diagnosis of AKI or ESRD, which is acute kidney injury or end-stage renal disease. And the reason for the 90-day period is it gives the patient who has newly been diagnosed a chance to adjust to the new lifestyle. It is very overwhelming and very stressful for them. And the clinic does provide some education to them, but I think many times during the stressful time, they are not comprehending these things because when at the hospital, when I ask them if they know this information, they say they've never learned it. So I really think they're not comprehending it. Because when I talk to the clinic, they say that they're giving this education in this first 90 days. The patient agreed to an education time of 30 minutes during the scheduled dialysis treatment is an inclusion criteria. and the patients could follow instructions or had a significant other who assisted in the care that could help follow the instructions. The exclusion criteria, they were under 18 or over 80. They were a new start less than 90 days. They had been on hemodialysis for over 6 years. They could not follow simple instructions. They were a prisoner or incarcerated, and they did not agree to the education. My budget, the only out of cost I had were for some pens, mileage, wear and tear on my car, and some refreshments for the participants. The total cost was $211.32. The dialysis company supplied paper, copies, educational literature, computers, the EMR, and the space and utility cost. The methods of evaluation, pre-education audit was performed before the teaching began to kind of get a baseline of how the patients perceive their own fluid and dietary compliance. 78 patients agreed to participate. Only 60 were included in the study. 18 patients were lost due to 12 withdrawing after we initially signed up. 3 transferred to another facility. 1 received a kidney transplant, and 2 died. The project was a quantitative exploratory design with a prospective and retrospective chart review with a teaching intervention in between. The aim was to see improvement in fluid overload compliance, decreases in pre-dialytic blood pressure, and hospitalization. A total of 60 patients were ultimately included in the study. Data was collected from the EMR 1 month before the teaching and 2 months after teaching. The delay of the 2 months allowed time for patients who will initially do maybe 2 weeks doing good and then go back to their old habits. It kind of gave that time to allow the patients who were going to be consistent to be consistent with their fluid restrictions. Data included in the collection process, the interdialytic weight gain, the blood pressure, the ultrafiltration, which is the amount of fluid pulled off, the number of hospitalizations for each patient, missed treatments or shortened treatments, and the albumin level. Albumin level, or the protein, is very important in dialysis patients. When this level starts getting below 2.5, they start having a lot of swelling problems, but when it gets below 2, it's really bad. And so they have a lot of third spacing because their vessels cannot keep the fluid inside the vessel, and it third spaces to the outside of the vessel. Education, the patients were given an individualized teaching session with the APN student concerning diet, sodium restrictions, fluid restrictions, and compliance treatment. The diet also included protein, how to manage the albumin, try to keep the albumin up, eating protein, and examples of protein and sodium restrictions were both given to the patients. Visual aids were approved by the dialysis company, and these were the only ones utilized. The patients could keep them for future reference after the teaching. Teach back and motivational interviewing methods were used, and questions were encouraged. Only the scholar provided the education to ensure all the material was covered equally for each patient, and there was periodic rounding performed to ask patients if they had any further questions. Data quality and adequacy. The patients each have an assigned machine that is used the same each clinic visit. They use the same machine. Each machine is equipped with a blood pressure cuff that performs automatic blood pressures and stores them in the computer. These machines are routinely inspected by the biomedical tech on premises yearly, and if there's any problems and the machines aren't calibrating correctly or they're not passing their test. Each machine is tested before patient use to make sure that it passes every test that it will run correctly. Scales are 0 before each weight, and the scales are calibrated yearly. They are floor scales that are built into the floors, and there's 2 of them, and then also the patient is instructed to always use the same scale. and the scholar did all the data collection. There is a larger population of African American patients due to the higher incidence of diabetes and hypertension in this population. 72% of the participants were African American, 25% were Caucasian, and 3% were Hispanic. According to the National Institute of Health and National Institute of Diabetes, Digestion, and Kidney Disease 2019 report, 6,437 persons per million with renal failure are African American. This is triple that of Hispanics and quadruple that of Caucasians. So this shows why there are more hemodialysis patients that are African American. And this is ethnicity distribution graphed out, showing more African Americans, and then Caucasian, and then Hispanic is the least. Gender distribution, 58% were male, 42% were female. Reasons for withdrawal from the study, again, included transplant, they died, they were transferred to another facility, or self-withdrawal. I also divided this up into African American and Caucasian, and male and female. I did not include the Hispanics because there was only two in this study, and it did not make much difference there. So the effects of time, a longer study would allow for more adequate follow-up with patients, and it also would allow those who will fall back into their old habits to do so, and that there would not be a skew in the data because, they initially do really good, but then they drop off. And so again, that's why that 2-month period was done before the post data was collected. The intergalactic weight gain results did show a significant change in the end. The p-value was 0.0463, and this is the changes noted from the pre-education and post-education data. Went from 12% that kept their weight less than 3 kilograms, and in the post data, we went up to 23% kept their intergalactic weight gain less than 3 kilograms. And again, it was found to be significant. On blood pressure changes, it was a significant result with a p-value of 0.0381. And on the graph, the pre-education, there was a 15% with blood pressures within good range, and we went up to 28% post-education. The hospitalization results were not significant. The p-value was 0.1546, and the interpretation was there is a significant decrease in compliance regarding decreasing intergalactic weight gain and blood pressure, and not a significant change in hospitalizations. And one of the reasons I thought that this was a problem, and these are the barriers, is I found that in collecting the data, the clinic only got the admission diagnosis. They didn't get the other coexisting diagnoses. So they could have been admitted with fluid overload, but their diagnosis may have said respiratory failure or congestive heart failure. But we didn't know exactly if they had fluid overload. So these were not in the hospitalizations as admissions. So in a future project, we need to find if there will be a better way to collect the hospital diagnoses to ensure we're getting the fluid overload patients. Because in my practice as a dialysis nurse, we see many patients with fluid overload, but they are there for other diagnoses. And I found that the data could have been collected in a different manner in the start. I should have done weekly averages. The way I collected it was the highest blood pressure or the highest UF. And what I saw in the end was the patient may have a good day, then they have a bad day, then they have another good day, so the week kind of balanced out. So I may have had better results in the end, even better results if I'd done it by average. Implications for future research, as I just discussed, adjusting the collection parameters, having a longer study, and reevaluation for the collecting hospital data. Uh, these are my references. I had multiple references talking about the different teaching methods, the teach back method, the um, motivational interviewing, how to enhance the self care and intergalactic fluid gain, and fluid restrictions. So there were many references that helped confirm my results I was getting. Thank you again for the time to give this presentation.